evening. I am your host, Arlana Shikongo, and tonight on Heartbeat, we are going to discuss the spike in COVID-19 infections and deaths and the resulting strain this has put on Namibia's healthcare system as the country is hit by a third coronavirus wave. In recent weeks, we have recorded both a record number of new infections and a record number of deaths. Just yesterday, the country had recorded 67,021 cumulative total infections, as well as 10,432 active cases, with 1,040 total deaths and 55,538 total recoveries. Just yesterday, 32 new deaths linked to the coronavirus were reported. Last night, President Hage Geingob also announced stricter restrictions, particularly for the areas in and around the Khomas region, as it has been pinpointed as the epicenter of the third wave. However, is Namibia prepared enough for this third wave? Or could it be that it is too little, too late? Joining me in studio this evening, we have Dr. Abdul Wahab Alanesi, who is the COVID-19 vaccine rollout consultant for the World Health Organization in Namibia, as well as Dr. Gordon Cupido, who is a Windhoek-based infectious disease specialist, and Dr. Izona Bok, who is also an infectious disease specialist, as well as a doctor in internal medicine, currently working in the Phoenix metro area in Arizona State in the United States. Thank you all for joining me. And I hope that we have a very, very fruitful discussion around the COVID-19 situation in Namibia at the moment, as it seems that in this third wave, things have become extremely dire for the country. So to start off, I'll pose the first question to Dr. Cupido. In recent weeks, the reporting in the media has been this problem of a lack of oxygen and a shortage of ICU beds, and how this is straining Namibia's healthcare system as our numbers peak in this third wave. So Doctor, could you kindly talk us through what this situation looks like on the ground at the moment?
So on the ground in Windhoek, as well as in many other towns, we find that patients are arriving at clinics, at hospitals, public and private, and are told that there are simply no beds for them.
Yeah.
So our health system has now been saturated with COVID patients. Our capacity to expand is limited, and essentially our facilities are overrun. Our health system is probably on the brink of collapse.
Oh, wow. To say that something is on the brink of collapse is a very scary sentiment to hear as a citizen of this nation. And I know that we have also had reports as to what the government's contingency plan is. Nurses that haven't been working for a number of years have been called back to duty. The government is trying to set up different, areas where patients will be treated, and also have cancelled any non-essential or non-critical surgeries and things like that. But Dr. Cupido, do you think that these measures are enough to mitigate the strain that is already kind of suffocating the system as it is right now?
I think not. And I would say that, for the following reasons. The one is the plain fact that patients are not finding beds.
Dr. Cupido, just give me, just hold on one moment. We lost you on screen. There we go. Okay. Keep going. Thank you.
The patients are not being admitted to oxygen providing beds the extent that they require. Our ICU capacity is now, our ICUs are full. Patients require anything more than face mask oxygen are dying because they cannot get into ICUs. Our oxygen supply is strained, and even patients who are on oxygen in hospital are often not receiving adequate oxygen because the supply is not sufficient.
Mm-hmm.
On top of that, then you've got newly infected patients who arrive, who are at clinics and have to stay at clinics because the bed and oxygen capacity in the hospitals is filled up.
Mm-hmm.
On top of that, you've got all the other diseases which have not gone away.
Yeah.
Those patients who still require hospitalization. And on top of that, you've got healthcare staff falling ill from coronavirus.
Mm-hmm.
You've got operations being cancelled or delayed.
Mm-hmm.
So, all the things that we do now are postponing certain costs into the future.
Mm-hmm.
Tuberculosis that goes undiagnosed, hypertension that is untreated, diabetes is untreated, trauma which is unattended to, malignancy, all of these things. So we are now ballooning a lot of our problems into the future,
Yeah.
while at the same time struggling to cope with what we have right now.
Mm-hmm.
We're still on the ascending level of the epidemic curve,
Mm-hmm.
which means everybody who was infected in the past week or 2 weeks will still come into the hospitals in the next week or two.
Mm.
So, where we are now is better than where we are going to be in 2 weeks' time.
Oh, wow. Wow, that is, yeah, that is quite a stark realization to have, because I think a lot of people do not think of that. The people that are being recorded as infected now, many of those people will end up in hospital needing oxygen in ICU beds. Moving on, though, to the next question, which really speaks to looking at the rate of infection in our country. We have from the Reuters COVID-19 tracker, I think they posted this on Monday or Tuesday, but essentially they detailed that based on our statistics, we have a 255 infections per 100,000 people reported over the last 7 days. Now, this is in comparison to India, where just last month, the world was really reeling in the panic of what was happening in India, that is now recording only 43 infections per 100,000 people in their population. And their population is completely, like, much bigger than the Namibian population. So, Dr. Bok, I wanted to ask you, these numbers are particularly worrisome for the country. Is it reasonable for a country as small as Namibia recording these numbers? Is it reasonable that there is such a panic about this situation?
For sure, because currently the level of infections in Namibia really necessitates what happened yesterday, which is the implementation of free restrictions.
Yes.
And I know for many Namibians, you really feel like these COVID restrictions are harsh, and especially for the economy, but I've heard somebody refer to them like chemotherapy. Chemotherapy for cancer, it's difficult, it has a lot of side effects, but it's the best tool that we have in our toolbox. And this is what the restrictions are for COVID right now. So, and just to say what you've been saying and also reiterate what Dr. Cupido was saying, we have the second highest daily cases per 100,000 in Africa right now, after Seychelles. And we have the second highest death rate in Africa per 100,000 after Tunisia. And like Dr. Cupido said, the numbers, unfortunately, we see those deaths coming right after the infections.
Yeah.
So the number of deaths are going to continue to go up, and we have to do something now. So I really do think what the government is doing with the restrictions is a necessary evil. Very few countries have the health infrastructure to deal with this kind of surge.
Yeah.
It makes it much more dangerous to get COVID. So a lot of people would say to me, for example, oh, there's a 2% death rate. So there's only a 2% chance that I'm going to die if I get COVID. But when you're thinking that kind of thing, are you considering there's no bed for you in the hospital? There's no oxygen for you in the hospital. What does that push the death rate up to? It's no longer 2%. So people really have to be considering that. And, I don't want, panic is a very strong word, because doctors like Dr. Cupido are working very hard, administering these medications. I have an aunt who's in the hospital and who is being taken care of very well. But, you have to consider, if there's no one there to catch you, what's going to happen.
Yeah.
You can expand the beds, but where do you get the doctors? Where do you get the nurses? And as somebody who's been very overwhelmed when we had these surges in Arizona, you cannot provide the highest quality of care that you would normally provide. And on top of that, you as the healthcare provider, I've had people say, well, it's your job. Just go to work and do your job. You're getting paid, but people forget that we are human.
Yes. Yeah.
We are working. We are anxious of getting COVID. I myself contracted COVID in the hospital last May. And I was very lucky because I realized I was exposed. So I quarantined immediately, and I was able to prevent from getting my family infected. But that's one of the things healthcare workers are concerned about. What's going to happen to me if I get COVID? And what's going to happen if I don't know I have COVID and I infect other people at home?
Exactly. Absolutely. Yeah.
Yeah.
And I mean, currently now, I think it's starting to sink in for people that this has less to do about you as the individual, especially the younger population, and more to do with the people that you're around, the people with comorbidities, the people that are elderly. I think it's starting to sink in now, because I don't know if you all have been following the news in Namibia, but over the last couple of months, which I think is why the president, had to tighten the restrictions. Over the last couple of months, people became, how do I say, relaxed, if I can call it that.
Yes.
Quite, it was almost as though people were moving around like the virus didn't exist. And I think that's why in this moment in time, we're seeing this spike, because suddenly, not only are people realizing, oh, I've been a little bit reckless, but people are also like, oh, I should go get tested because I potentially have been exposed. That said, on Tuesday, or actually yesterday, we hit 1,000 COVID-19 deaths related to COVID-19. And this is from when the pandemic onset last year. And I really want to ask Dr. Alanasi how this figure speaks to the projections that the World Health Organization had for Namibia in terms of where we would see ourselves about a year and a few months after the onset of COVID.
Thank you very much. I think it's like an agreement. Everybody understand now that there is a spike, and the trend is going high. And unless a very strong action is taken, otherwise, it's something that cannot be controlled. But what's happening is that if we are going with between 1.5 to 2.5 to 3 fertility rate, and then it means it's increasing. If you see to the lab testing, and you see that the positivity rate, I mean, out of the people who have been tested for COVID-19, that is a few weeks back it has come down to something like 8%, but not 8%. But last 2 weeks it was 24%,
yes.
And it's going now maybe more.
Yeah.
I think the situation is very crucial. And as you mentioned, one thing is very important. This virus is serious. We should be more serious. It's a serious enemy to everyone. It doesn't know who is there, just it knows that what is the chance to harm someone. So we have to be very serious. It's a relaxation. You see, India is one of the major even vaccine producing countries, right? Somewhat, and India was going fine. The curve was declining, was going down, but some relaxation. Some relaxation for some events. There were some political campaign, election campaign, and there were some religious events, and people gathered and they relaxed in using the public health preventive measures.
Yes.
And you see what happens.
Absolutely.
And there is one thing important is that, unless, there are things that everybody can do. What? Mask, everybody can do.
Yes.
Social distancing, everybody can do. Hygiene and hand washing, everybody can do. Okay? So these things are more preventive, and they will cover, the largest portion of the protection until we reach by the vaccination program to our target, which we want to reach to the herd immunity. So I think the situation is crucial, it's very critical, and has been declared by the highest level of the government, His Excellency the President. And I think if you have read or heard the speech yesterday, it was really it has moved my emotions.
Yes, yeah.
It has moved my emotions. There is nothing like instructions. There is nothing like just a law. It is just appealing to the people.
Yeah.
Please, please, protect Namibia
Yeah.
and protect the whole world. And nobody will be safe unless everyone is safe.
Absolutely.
Yeah.
I actually saw an interesting comment on Twitter earlier today where somebody said, hey, everybody, COVID-19 is a group assignment. We have to do this together. And I thought it was an interesting comment because it's humorous, but it also speaks to the nature of this virus. It's not an individual thing. It's a team effort, and it's a global effort at that. So everybody does have to, you know, step up and play their role. And in Namibia, we're seeing that a lot more now as these numbers are going up. But I do want to speak on the anticipation, rather, of a third wave. We've seen other countries hit by their second and third waves, and I think everybody knew that a third wave was going to come. It was somewhat anticipated. However, the country still seemed quite ill-prepared, especially when it came to oxygen and ICU beds. It seemed like during our second wave, there were no active steps taken to prepare for the potential of a third wave that could be drastically worse than what the first and second waves look like. So just based on the information that you have, the news that you've read, what you're seeing in the spaces that you work in the local communities as well, was Namibia prepared for this third wave? I think, Dr. Cupido, let me throw that to you first, and then we'll go around the room.
I think, to be fair, very few countries have been geared for the succession, the waves which have come. Mm-hmm. And I think that's partially because of the evolution of the virus. We know that even in South Africa, the second wave was much worse than the first, much worse than anticipated. India, the same thing. In the UK, they are now having to postpone their opening because of rising cases. So this virus does not necessarily follow any rule book, and many people have been caught out. We're not the only people to have been caught out by the ferocity of this third wave.
Yeah.
But I think, seeing what happened in India, that should really have, and has, I think, in many quarters, raised alarm bells. The fact that we are in the situation that we are is because, as you said, very few health systems, if any, are geared towards this kind of rapid, almost catastrophic healthcare challenge. So maybe we could have done better, maybe we should have done better, but now that we are where we are, we really need to step up our efforts at containing the transmission, step up our efforts at vaccination, step up the regulations regarding movement, mixing, gatherings, and this effort to expand hospital beds, to improve oxygen capacity, to hire more staff in order to be able to treat people better. These things are, I think, in full swing. But to your question, should we have seen this coming? Hindsight is always perfect. And, I think we probably could have done a better job of anticipating what is happening now.
Yeah. Dr. Alanesi, I'll pose the same question to you. Were we prepared enough, and where did we fall short in our preparedness as a country?
Well, there is a COVID response plan.
Yes.
And there is the national development vaccination plan. They are in place, and their operation really started. But the challenge is big. I want to say one thing to our respected audiences, very important. Just to give an example, you have a bicycle. It has two wheels. If you puncture one, it will not go.
Yeah.
So it's like the government and the people. They are the two wheels of that bicycle. Unless we are cooperative with each other, and we take things as a health issue and only as health issue now. We don't talk about anything else. Give it the priority, and it will work fine.
Okay.
There are things that are very strongly prove they are very effective. Let us say the history of when this SARS-CoV-2 COVID started in China. At that time, even there were no vaccine. But everybody had seen what procedures, what regulation, how was the community compliance and adherence. And then within a weeks or months, the curve was flattened.
Yeah.
But even with that, I remember I was traveling twice. It happened to me twice when I was in travel. And I see 3, 4 guys, they are wearing the complete PPE, personal protection equipment. I say, when I came, they are Chinese.
Okay.
They are going with us on the same flight, so they are afraid of everyone. So people, when you become very strict and you can do a lot of things, and because and even one thing is that also the vaccination is very important as well.
Yeah.
And that's why now even China is one of the major also, manufacturers of the vaccine. Yes. So these things we need to work with. It is a complete strategy. It works as a system. Otherwise, our quality will not be enough to defend. Yeah.
Absolutely. And Dr. Bok, from the outside looking in, you're based in a country where for a while there in America, it was a very, very bad situation. So from that perspective, looking in, what would you say about Namibia's preparedness for this third wave?
It's like Dr. Kubro said, I think that many countries have been caught almost a little bit unaware. And I think one of the big issues in Namibia is we're dealing with the South African variant. The South African variant, it's the predominant strain that's circulating right now in Namibia. It's much more infectious. So they estimate that it's about 50% more transmissible. So that means it's easier to catch it, it's easier to spread it. And in South Africa, it had a higher in-hospital mortality as well.
Yeah.
So the problem is you're spreading that virus days before you even know that you're infected.
Yeah.
And what you had mentioned before with pandemic fatigue, we are social creatures.
Yeah.
We want to be near others. We're feeling depressed. And what happens is we take our mask off that one time, or we go to that wedding that one time, and nothing happens. So what do? We keep on with those same type of risky behaviors.
Yeah.
So now you have pandemic fatigue and you have the terrible variants that are coming out.
Yeah.
And what we have to do is really get the vaccine started and really get people to accept the vaccines as well.
And there definitely has been a major push to get people vaccinated in Namibia. There are many different campaigns going on. Restaurants are offering people burgers and things like that if they go get vaccinated, just as sort of an incentive to motivate people to go get vaccinated. However, a problem that we also have here is there's very strong pushback against being vaccinated. We have a lot of people that are reading, conspiracy theories, reading information that are not coming from medical journals or reputed or verified sources, but people are absorbing that information, and we're seeing it, even in our families. We have anti-vaxxers suddenly out of the blue. We have so many people that are anti-vaxxers. So this raises the question on two ends. On the medical end, how is the vaccination program looking? And then on the World Health Organization end, are we living up to, or are we achieving the standards that we had set to have in terms of how many people we have vaccinated at this point in time? I'm not too sure on the specific data, but if I'm not mistaken, we have less than 20,000 people fully vaccinated at the moment. And we have close to, I think, just above 70,000 people that are yet to get their second dose. They have their first dose, but not yet their second dose. So once that happens, we'll be coming close to having just about 100,000 people vaccinated. But, Dr. Alanesi, I'll pass this to you. Are we performing in terms of our vaccination drive? Is it enough, or do we still need to get more people vaccinated?
Well, you see, you have two vaccines, and the rollout started officially on 19th of April, just in about 2 months back. And about, now we could say by today, I guess about 100,000 doses had been administered, right? Now, these two vaccines, one of them is the Oxford AstraZeneca, where the difference, the gap between the two doses is from 8 to 12 weeks. But the other one is the Sinopharm, where the doses are taken within 3 weeks, right? Even with one dose, it works for some time until you get the other dose. So there is a protection, and you could say, but if you see, if the target of the National Development Vaccination Plan is to immunize, to vaccinate 1.5 million of the population, because the strategy is to reach, 60% coverage and to have the herd immunity. In that plan, there is a prioritization for the priority group. That is the frontline health worker, the elderly, the people who are having comorbidities, and so that these are the people who are more at risk. Okay. So if you could say that you have given you have reached 90,000 people, okay, it's fine with the availability of the vaccine. Actually, the shortfall of the vaccine is a global problem, But as we observe that what vaccines has arrived to Namibia are utilized. And even today and yesterday, they are discussing that to ensure that you should not be, stuck out. To that, the ministry is trying their best to get more vaccines to come. So, but there is one thing very important. You see, to build a tower, it takes you years. To destroy it, it takes you seconds. Yeah. This is what the pushback people are doing. We want these people push back. They were pushed back since the start of the COVID. Maybe you have heard people when the COVID started, they say, this is not true. This is not a virus, blah, blah. But then the virus said, I am there, I am here, I am everywhere. We are talking about more than 170 million people has been infected. Now we are globally, we are talking about approaching 4 million, losing 4 million lives globally. So the virus said, I am there. Yeah. And then when people started to do the campaigns, it's not just in Namibia, even in many other countries, they start and make videos and this and. But what happens now? The vaccine is saying, I am there. And we have seen the effect of vaccine in the countries where a high administration of doses has been there. So even in India, by the way, within a weeks, you imagine, please look to the curve of India, which was the highest at the end of April and May. Please go to it, the internet is there, and see how the curve is going down. Yeah. So I think vaccine is one of the most effective role, but we want to say there is something we can act now. We can do it now. The public health preventive measures, mask, hand washing, that's we need to repeat. Hand washing, respiratory etiquette, ventilation, all these things, avoiding gathering, as doctor said, So we have to apply everything. And one thing, if I see that, if you see the data, a few weeks back before the school opens, the infection among children, students, and teachers was less. Yes. Now the schools open and it went up. Absolutely. So this is a sign that gathering is really a problem. Yeah. People have stopped even the Olympics and football matches and so many things globally. Exactly. Yeah.
Yeah. Dr. Cupido, still regarding vaccines, I want to know from you, having worked on the ground, how has it been working with the different types of patients that are partially vaccinated, patients that are fully vaccinated, and then patients that are not vaccinated at all? If you could paint a picture for us of what it looks like in a day when you're dealing with these three different groups and what the experience has been overall.
So the absolute number of people who have been vaccinated compared to the population is small. And amongst the patients who fall ill and present to hospital, it's a minuscule fraction who had even one dose. Yeah. What we've seen, and this is anecdotal, of course, is that many people have the vaccine probably while they are incubating the virus. Because they fall ill fairly quickly. They show symptoms And some will even recollect that they had symptoms prior to having the first dose of the vaccine. But up till thus far, at our unit, I think we may have had maximum 4 out of almost 300, over 300 patients who have had the one shot of a vaccine. In other words, 99% of the patients who present, who are ill, have not been vaccinated, have not even had one vaccine. And the ones who have been vaccinated likely had been infected shortly before. We also know that the vaccines differ in their efficacy after the first versus the second dose. So the AstraZeneca is much more effective after the first dose. Both are equally effective after the second dose, but it still takes a few weeks, for that effect to manifest itself. So very few people who've been vaccinated become ill, and even fewer people who've been vaccinated become ill enough to have to come to hospital. And no one who's had the second dose, to my knowledge, has been admitted to hospital. So that tells us that the vaccine is extremely effective at keeping people out of hospital.
Absolutely. I actually want to go into, I think, Dr. Alanesi, you mentioned this a little bit, just about these conspiracy theories and ideas that exist. We had a couple that came across our news desk. So I'm going to just have everyone debunk one of these conspiracy theories that are floating around. So Dr. Bok, I'm going to have you go first. There's one on the Singapore autopsy on a COVID-19 corpse. There's this circular that's going around. I don't know where it came from, but one of our readers forwarded it to us from WhatsApp. But essentially, the circular says that it was discovered COVID does not exist as a virus, but rather a bacterium that has been exposed to radiation and causes human death by coagulation of the blood. Now, see, that sounds very medical and very possible to be medically true. So I can understand why someone would read that and be like, this is true. I can believe this. But please, Dr. Bok, take us a second to walk through that logic and how do we tell people or show people that this is not how the virus works?
Yeah. So first of all, let me just give some credit to the people who come up with these creative stories.
They're quite good at it.
But, the thing is that misinformation, it stems from a distrust of the scientific community. So it's forums like the one that we're having right now that are so important because people can actually see who are the doctors who are taking care of me, who are the people in the scientific community who are assessing this data. Do they seem like they know what they're talking about? You know what I'm saying? So you really have to build that trust with people. And I'm really grateful that you allowed me to be on this forum today. So conspiracy theories, they can be so powerful and very dangerous. So I really want to implore people, think before you forwarding these things on. We had a patient in the hospital who said, COVID is a hoax. She was sick. She was needing oxygen. We said, we need to give you these treatments. We need to do this. She said, no, COVID is a hoax. I don't want any of those treatments. And by the time she finally accepted the treatments, it was too late and she passed away. So these kind of misinformations that we're passing between us, passing from family members, be very careful. So before you, and when you get this information, what can you do? So you're looking at this and you're saying, okay, there are blood clots from radiated bacteria. So first of all, ask yourself, people say, oh, the scientists say these blood clots. Which scientists are these? Look into it yourself. Immediately, when I looked up this particular claim on Google, it says Ministry of Health in Singapore says this is a false claim.
Exactly.
Right? So don't just take that WhatsApp and forward it on. Actually go and look it up. And then look at the information. For example, that particular one says the World Health Organization has warned against autopsies for COVID-19. But actually, if you think about it, one of the first things that we did as a scientific community was to actually do autopsies on patients with COVID-19 to see how does this virus work? What does it cause so that we can go backwards? to see what therapies can help.
Yeah.
So you really have to have a little bit of that critical thinking that is going on when you're seeing these things.
Yeah.
And like really look into the information before you forward it on, because not everybody is going to be, people are so easily swayed.
Absolutely. Dr. Alanesi, I'm going to send this one over to you because it has to do with vaccines. But this claim is that one must test negative before taking the COVID-19 vaccine. This is the scientific truth and common sense, but authorities are not telling people.
Why you are making me laughing?
Doctor, these are...
Because I'm seeing it clearly.
Yeah.
And people can go to the WHO website and see the guidelines there. Even specifically in Namibia, you have the two vaccines, AstraZeneca and Sinopharm. The recommendations say WHO doesn't recommend to make COVID test before getting the vaccine. Clearly, there is no need for that. So this is not a scientific truth. As the doctor said, we have to think of the source.
Yes.
You know, if you want something to be published in a peer medical journal, like Lancet or other, people to sometimes one page to have a chance to put one article for 1 or 2 pages, it takes you 3, 4, 5 months for somebody, which is sometimes granted for a PhD degree. And now, if you see what is happening about this information, when it comes from WHO is looking to the information globally. Okay, and we have to act locally.
Yeah.
You know, we are looking to the studies which are being conducted in the Asia, America, China, everywhere, and there is a global, we call it the strategic advisory expert, the SAGE, which is the Strategic Global Advisory Expert of Experts, and they are from different parts of the country. So this is not true at all.
Yeah.
Not true at all. And this is the thing that, people who cannot play science, they go and play politics. I'm sorry for this. But this is a political thing. We don't believe in politics. You see, the virus has hit even head of states.
Yeah.
In different places.
Yeah.
And they said, we had the virus. So they accept it. So this is the fact that there is no recommendation to make COVID test before you get the vaccine. That's not recommended.
Thank you for clearing
Yes.
that up, Doctor. And then the last one that I'm going to send over to Dr. Cupido. Is he still with us? I'm not too sure. Is he? I don't...
Disconnected?
He may have disconnected momentarily. Yeah. But then, okay, I can actually throw this to you too, Dr. Bok, then. This one says, when one is COVID positive and goes for testing and goes for vaccination instead of treatment, that's like suicide. Let me repeat that one again. Dr. Cupido, you're back. I wanted you to debunk this one for us. It says, when one is COVID positive and goes for testing and goes for vaccination instead of treatment, that's like suicide. Sorry, Doctor, I don't think we have sound from you. Just quickly have a look at your sound setting and make sure that you're unmuted.
Am I back on?
Yes, you're back on. Thank you.
I'm not sure what the basis of that, that would be.
Your sound is cut. It's a good.
His sound is back.
So-
His sound is back.
So, natural infection, when you've been infected with or without symptoms, induces some degree of immunity, but not complete immunity. And it means that even people who have been infected are at risk of reinfection, particularly from, A, a different strain, and B, a varying amount of time after that initial infection. So everybody, whether they had previous exposure, infection or not, should be vaccinated. So I'm not sure what the logic of that would be, that suggestion that once infected, a vaccine would then, give you the killer or the loss. That doesn't make sense. I'm not sure how they justify that.
Yeah, I think a lot of people's logic is that, first of all, a lot of people think that these vaccines have an active element of the virus in it, which actually we have a question here from one of our viewers, Nancy Dunaiski, that's in that same vein. So I'll just read it to you. It says, what is in the vaccine? What are the side effects? And do you have a plan to control the severity of the effects? And what would that be? Again, speaking to, people are not sure about what is in the vaccines, which is why it's so easy for them to consume this information that says A, B, and C. So if we can just speak a little bit about the two that are available in Namibia, at least, the Sinopharm and the AstraZeneca. What exactly is in these vaccines?
So what you have is that you have an inactivated, a dead virus, which carries the protein, and this particular protein, which is from the coronavirus, is the one which your body reacts against. The inactivated virus is one that we've been exposed to from childhood. So we have immunity to that virus. Because it's dead, it's inactivated, it cannot cause infection. The spike protein, or the protein that the coronavirus would use to infect our cells, then is the one that we produce antibodies to.
Okay.
So this virus cannot multiply inside your body. The dose that you get, it remains at that dose. It does not cause any further damage to your body cells. Now, side effects, most vaccines have got mild side effects, which pass very quickly. Most people don't get any side effects. Some people might get a tingling at the site. They might get some injection, some reaction at the site of the injection. Some people might get chills and fevers, which is a manifestation of the fact that your body is mounting an immune response against this thing.
Yeah.
And the management of that is with paracetamol, fluids, rest, that kind of thing. Very, very, very few people actually develop severe complications. And we know about this because people are monitored so closely, particularly in Europe and the USA, where they have used these vaccines. So we know that very, very few people get, it's in a range of 1 to 5 per million who get this severe complication, compared to 1 to 2 to 3 per 100 who get severe complications from coronavirus and potentially die from coronavirus.
Yeah.
So we're talking about a 10,000 times increased risk from getting coronavirus versus complications of the vaccine.
Yeah.
And to further reduce the side effect, we actually recommend that people, certain age groups and certain genders, take the one vaccine versus the other. So, scientists, doctors are extremely careful. These vaccines have been given to hundreds of millions of people all over the planet. And the cases of people who've had problems, probably can be counted on the fingers of two hands. So we should really not amplify this, as an argument against vaccination.
Yeah, absolutely. We're running short on time, but we do have quite a bit coming in from our readers. So I'm just going to read a couple more. We have one here that says, just hold on one moment. It says, sorry, the comments are moving, so I'm a little bit lost. Okay, it says here, okay, there's a specific one here that says, the vaccines that we have, AstraZeneca and Sinopharm, how effective are they against all the variants? The SA variant that's now present in Namibia. Let me just repeat that. The vaccines that we have, AstraZeneca and Sinopharm, how effective are they against all the variants, given that the SA variant is now present in Namibia?
So I can answer that question.
Yes, okay, go ahead, Dr. Bach.
So the South African variant, it is when you are doing studies on the vaccines and you're looking at the specific virus outside of the body, there you do see that there is a drop off of how effective that vaccine may be. So specifically for the South African variant and the AstraZeneca, there is some evidence that it's not as strong against the South African variant as some of the other vaccines may be. However, the study was a smaller study, and on top of that, it's the way they did that study is they excluded people who were of a certain older age range.
Okay.
So none of the people who were in that study actually got any severe COVID. So nobody could say whether the AstraZeneca is preventing the severe COVID, or do you understand what I'm sort of meaning?
Yes.
So in other words, there were no severe cases of COVID among those people who were vaccinated or who were not vaccinated. So they could not say with AstraZeneca whether in the South African variant specifically. If you're looking across the globe, though, at all the other variants, the AstraZeneca is a very good vaccine. It has very low side effects. And it's like Dr. Kibro said, it's really, if you're looking at how many people get blood clot, for example, from having COVID, it's, tens to thousands more people getting blood clot versus somebody getting it from the AstraZeneca vaccine.
Okay.
The Sinopharm vaccine, again, it has been studied. We do not have studies for South Africa specifically, but it works very well in Turkey, and it has more than 50% in Brazil.
Okay.
And we do know that the Brazilian variant is also one that has been quite aggressive.
Yeah.
So basically, from what we're seeing, these vaccines do work. We're just still waiting for all the data to come out in terms of to give you those exact numbers.
Of course. And
For
then
South
there's
Africa, but we know for the world. We know them for the world.
Yeah.
We just don't know them exactly for South Africa.
Yeah. There's one more here that Dr. Alanesi, I want you to speak on perhaps, because this is the one that is now very prevalent among the population and among the group of people who are very scared of the vaccines. And it has to do with the DNA aspect of it. So this person asks, please tell us and let us know, how long does the vaccine last in the body? And also tell us, why is the vaccine ready in such a short period of time after all the theories that it might take up to 10 years? So that's twofold. How long does it live in your body, and why did it come out so fast?
Number one, how long it lasts. After the recipient get the vaccine, the body is triggered to develop the antibodies. So it trains the body, and to make what you call it a seroconversion until the production for the antibodies are produced, it depends on the vaccines. For example, in AstraZeneca, it takes 3 to 4 weeks. And Sinopharm, it takes 2 weeks after the second dose.
Okay.
Whatever. So this is the time. This needs, I think, by itself a separate session to discuss.
Yes.
What is more important is that the other part of the question, which is a good question, that why these vaccines has been developed in this record time. Number one, the vaccine manufacturers, they have gained the experience of the last 50 or 60 years of producing vaccine.
Yeah.
Secondly, the technology has been advanced so much. Thirdly, the countries has motivated and invested a lot in it. Now, you can imagine there are more than 270 candidates. They are of vaccine manufacturers. They are trying to get their vaccines approved, licensed. Only a few, like 5 or 6, which has got the emergency use list. So there is a big competition. But one of the things is that in the old times, people, they were when you develop a vaccine, first there is one phase you call research. You have to conduct a research. Then you have to try it in the lab. Then you have to try it in an animal. Then you go in a human trial, clinical. We call it clinical trial. In the clinical trial, you try the vaccine in tens of people who are volunteer.
Yeah.
You succeed, then you try the second phase on hundreds of people. Then the third phase, you try it in thousands of people. But this vaccine, because of the need, it has been tried. If some of them they have been tried, the sample of the trial has reached to 30 or 40,000 people. Now there is one figure very important. We want people to just feel safe. Imagine more than about 2.5 billion doses has been administered. Tell me how many people have been killed by the vaccine.
Yeah, it's very small.
You see, you have given more than 2.5 billion jabs, and you see. But then the other positive part is that you see that how many in the countries who have got a higher vaccination, how their curve is going down.
Yeah.
Now the vaccine, there are DNA vaccine, there are mRNA vaccine, and there are the protein particle part of the spike protein vaccines. This is also need a separate session to talk about it. But these vaccines, they are just, when they come, they don't stay in our body. They stay for a certain time. They train our body to develop self-defense. Our immunity cells, they know the enemy. And they produce the antibody against that enemy. And it's very long to talk. There are some memory cells in our immunity system. They keep that one in the memory. Hey, your enemy character is like this. When it comes, you attack.
Okay.
So in the first dose, the first jab, the immune system is triggered. The second jab, the memory is triggered so that it protects for a long time. Now the last phase of vaccine production is called the post-introduction phase. The post-introduction trial, which is the fourth phase. What is it? Like now, in the emergency using list, which has approved this number of vaccines, these vaccines are rolled out, right? Because they have passed the 3 trials. The fourth one is that from the rollout, it takes us 5 to 10 years. We keep monitoring globally the vaccines. After 5 or 10 years, then we can see this is okay. So the vaccine is safe. It doesn't go to the introduction to roll out unless it is safe. And this is what we want people to carry.
Okay.
Vaccine is safe. Yeah.
Okay. We have a viewer asking here just one last question because it's quite an important one. Can pregnant women take the vaccine?
Yes.
They can?
Yes.
Doctors?
So in America, we are using the mRNA vaccines, which is the Pfizer and the Moderna, and those have been safe in pregnant women. And one of the things that we're saying is if you get COVID, your risk to the baby and your risk to yourself is so much higher than any type of risk from the vaccine. But I will let Dr. Cupido answer that in terms of the vaccines available in Namibia.
Yeah. Dr. Cupido?
Yeah, so this, the safety data, I'm not aware of the safety data with pregnant patients now. But as Dr. Barker said, COVID in pregnancy is a highly, is very hazardous. So in a situation like ours, when we are in a third wave and infections are rampant, these vaccines may not have been tested or safety data might not be available. But on the balance of a risk-benefit calculation, one would probably advocate right now for vaccinating as many people as you can with the vaccine that you have. And given that AstraZeneca seems to be more problematic in younger females, probably the Sinopharm, if one had to choose one of those, would be a better option for us.
Okay.
May I add one thing?
Yes, go ahead.
Actually in pregnancy, the risk of having COVID is more than in the non-pregnant woman.
Okay.
This is number one. Number two, the WHO don't recommend even pregnancy tests for having the vaccines, which are even now used in Namibia, Oxford, AstraZeneca, and Sinopharm. You don't need to make a pregnancy test.
Okay.
If someone is pregnant, she don't need to terminate pregnancy to receive the vaccine.
Okay.
Now, in certain situations which are very rare, and someone is under the care of the family doctor or the gynecologist, and they know this situation because, some ladies, they are not only pregnant, they may have another health problem along with pregnancy.
Yeah.
In that one, there is some sort of consultation should be given to the pregnant woman, and it should be explained clearly the risk benefit, the risk of the COVID-19 and the benefit of the vaccine, and should be given the option which vaccine she should select. Okay, and then the vaccine is voluntarily. It is not. There is no compulsory. There is nothing to be given to anybody in medicine. Even you cannot give a distilled water without consent.
Yeah.
Yes.
Yeah. Absolutely. Well, thank you, Dr. Alanesi, for clearing that up. And Dr. Bok, Dr. Cupido, we are coming to the end of our program, and I know that, our readers have tons more questions, which I think can be forwarded to you, and they can get answers through me from you all as well, because unfortunately we just do not have the time to get to them. However, I want to thank all our guests for joining us this evening. It was a much needed discussion on COVID-19, seeing the current situation of Namibia. So for our viewers at home watching, I hope it was informative, educational, and I hope everybody stays safe. As for me, I'm your host, Arlana Shikongo. Have a good evening.